السلام عليكم. ازاي حضراتكم عاملين ايه؟ انا دكتوره مها بندق، استاذ مساعد اندوكراينولوجي قسم الاندوكراينولوجي جامعه اسكندريه. and I'll be with you today for one of the endocrine disorders, hypopituitarism. يعني simply when the pituitary fails, when the maestro fails, when the master of our all endocrine function fails. First of all, قبل ما to go for a definition of hypopituitarism, we need to know what is the pituitary. So the pituitary is the master gland which ultimately controls all the endocrine function of our body. From the pituitary gland, from the anatomical point of view, it is divided into two loops, the anterior loop and the posterior loop. The main hormones arising out of the anterior of the pituitary gland arises from the anterior loop. From the anterior loop, we are having 5 basic hormones coming out of the anterior pituitary, namely growth hormone and prolactin, LH and FSH, namely the gonadotrophins, the TSH stimulating hormone, and the ACTH adrenocorticotrophic hormone. So we're having 5 basic hormones coming out of the adenohypophysis, which is, that's to say, the anterior pituitary loop. The synthesis and the secretion of these 5 basic hormones is going to the anterior loop, while the posterior pituitary hormones, namely oxytocin and antidiuretic hormone, having the other name of vasopressin, it is only stored and released out of the anterior pituitary. However, the synthesis of these 2 hormones is coming from the hypothalamus, from 2 important nuclei, namely supraoptic and paraventricular. So supraoptic and paraventricular nuclei synthesize the posterior pituitary hormones, and passing through the pituitary stalk they are going to be stored in vesicles within the pituitary, the posterior pituitary loop, and they are going to be secreted upon appropriate stimuli. So this is the pituitary gland. As you can see here, an MRI showing the normal study of the pituitary gland. The pituitary gland lies here at the base of the skull, above the nose, the sphenoid bone, sphenoidal air sinus, and here lies the pituitary gland. As you can see here, this is the pituitary, the hypothalamus, and upward extension to the pituitary gland, and the whitish line here representing the optic nerve. So the optic nerve is the whitish structure here. This is the pituitary gland. Mind you that the pituitary gland lies at the base of the skull at an area residing in an area known as sella turcica. Sella turcica, the pituitary gland is residing in anterior extension or anterior anatomical relation to the pituitary gland, the optic nerve. So this is a very important anatomical consideration when we speak about the pituitary. The upper surface of the pituitary gland is said to be concave upper surface. And if the patient is going to harbor any enlargement within the pituitary gland, any sort of a tumor known as pituitary adenoma, this upper concavity will be converted into convexity. And if we are going to see that the pituitary gland is having an upper convex surface, this is not normal, and it most probably indicates the presence of underlying adenoma. This is another coronal section of the pituitary gland. As you can see here, this is the pituitary gland, the normal study of the pituitary gland based upon MRI. In lateral extension of the pituitary gland, we are having the carotid arteries, as you can see here, the cranial nerves, namely the cranial nerve number 3, oculomotor nerve, trochlear nerve, 4th cranial nerve, the 1st and 2nd division of the trigeminal nerve, the 5th cranial nerve, and the abducent nerve. All of them, they lie in lateral extension or in lateral anatomical relation to the pituitary gland. Upwards, we are having the hypothalamus, as an anterior, as I have mentioned before, we are having the optic nerve, the optic chiasm, and the globe. So here the pituitary, the carotid arteries, the optic chiasm here, the whitish horizontal structure here, and the pituitary gland. And here we are having the sphenoidal air sinus, as I have mentioned before. So in upper extension to the pituitary, we are having the hypothalamus, the one having upper controlling, the upper controller of the pituitary gland, the hypothalamus. From the hypothalamus, it releases a set of substances known as strobic hormones. These strobic hormones either enhance the secretion or inhibit the secretion of the 5 basic anti-pituitary hormones. So, as you can see here in the diagram, this is the adenohypophysis, the anterior pituitary gland, from which arises the 5 basic hormones I have mentioned before. Controlling these 5 basic hormones, tropic substances or tropic hormones coming out of the hypothalamus. Both growth hormone and prolactin, both of them, they receive both releasing and inhibitory hormones out of the hypothalamus, while the gonadotrophins, namely LH and FSH, the ACTH controlling the adrenal gland and the TSH controlling the thyroid gland, they receive only inhibitory substances or hormones coming out of the hypothalamus. So the hypothalamus controls the secretion of the anterior pituitary through these tropic hormones passing from the hypothalamus to the pituitary through the pituitary stalk, or the connection between the hypothalamus and the anterior pituitary. So as coming from its name, from their names, the gonadotrophins control the secretion of both testicles in males and ovaries in females. Prolactin, mostly responsible for lactation in females. Adrenocorticotrophic hormone, which will ultimately control the secretion of both cortisol and adrenal androgens out of the adrenal gland. The thyroid stimulating hormone, which will ultimately control the secretion of thyroid hormones, namely T4 and T3. T4, despite being released abundantly as compared to T3, T3 is considered to be the active thyroid hormone. Coming out of the pituitary hormone, posterior pituitary, the stored posterior pituitary hormones, oxytocin is engaged in the process of lactation by inducing ejection of milk through the mammary ducts, and oxytocin definitely is engaged during labor by enhancing the labor uterine contractions. Antidiuretic hormone, as it's coming from its name, or the other famous name of the antidiuretic hormone, the vasopressin, it controls the water and electrolyte balance through the release of the vasopressin. So controlling all our endocrine system, a set of feedback mechanisms. The upper controllers are said to be here demonstrated by the hypothalamus and pituitary. These are the upper controllers, and they are going to control the secretion of the target organs, namely adrenal gland, thyroid gland, the gonads, the ovaries and the testicles, and the peripheral action of growth hormone and the peripheral action of the prolactin, namely on the mammary glands. So, as for example, if you are having cortisol diminished secretion out of the adrenal gland, they are going to send positive stimuli on the upper controllers, the hypothalamus and the pituitary, to enhance their secretion in order to restore normal levels of cortisol, and vice versa. If you are confronted with a patient having high levels of cortisol, there would be a suppression of the upper controllers, the CRH coming out of the hypothalamus, the ACTH coming out of the anterior pituitary in order to store normal levels of adrenal glands, say for example if I'm having a problem in the adrenal gland. So this is said to be a feedback mechanism, a negative feedback mechanism. So an inverse relation between the upper controller, the hypothalamus and pituitary, and the target organs, namely the target endocrine glands, either adrenal, thyroid, gonads, peripheral action of growth hormone, and the mammary glands. So what about hypopituitarism? How am I going to define hypopituitarism? So hypopituitarism is simply failing of the pituitary, either manifested by diminished one or the whole secretion of all pituitary hormones. So either isolated hormone deficiency or a band hypopituitarism where all pituitary hormones are failing or are deficient. This disorder is associated with increased risk of mortality, namely due to increased risk of cardiovascular morbidity and respiratory diseases as well. So hypopituitarism should be taken into consideration, should be managed well, should be investigated and treated well in order to avoid increased mortality risk in such patients. Mind you that most cases of hypopituitarism, the clinical picture is slow and insidious. This is why these cases may be underestimated and underdiagnosed, and the patient may come with many complications that we need to avoid by early identification of this disorder. Mainly the signs and symptoms related to hypopituitarism, they are depending upon two important factors: the rate of onset of the disorder and the magnitude of the damage within the hypothalamic pituitary target organ damage. Hypopituitarism is simply due to a primary event affecting the pituitary gland itself, or to a secondary phenomena affecting the hypothalamus controlling the pituitary gland or within the pituitary stalk. So either the pituitary is having a problem within the pituitary itself, and this is a primary event causing hypopituitarism, or a secondary event from the upper controller, either the hypothalamic affection itself or interruption of the stalk connecting the hypothalamus and the pituitary. Causes of hypopituitarism, either genetic or developmental causes, that's to say congenital causes or acquired causes. Mind you that most probably when we are confronted with cases of hypopituitarism, they are due to acquired rather than developmental causes. So if you are going to review the genetic or congenital causes of hypopituitarism, they are going to be said to be very rare as compared to acquired causes of hypopituitarism. And I'm going to pass rapidly for examples of genetic or congenital anomalies that may lead to hypopituitarism. Acquired causes, as I have mentioned before, are said to be the vast majority of causes causing hypopituitarism. I could remember that in order to be simple and easy for you, in order to mind yourself and remind yourself with the causes of hypopituitarism, they are grouped under the 9 I's for the acquired causes of hypopituitarism: invasive causes, infarction, infiltration, injury, immunologic, iatrogenic, infectious, idiopathic, and isolated. So if I'm going to think about the causes of hypopituitarism, please remember the 9 I's. I'm going to thoroughly pass through them after a couple of minutes. Most of the causes leading to acquired hypopituitarism are affecting either the pituitary or hypothalamus, or they may affect both of them. I'm having a big mass that may compress both hypothalamus and the pituitary, leading to hypopituitarism. This slide or this table shows the major causes of hypopituitarism, acquired causes, either pituitary diseases or hypothalamic disease. And as you could see here, that the mass lesions are among the causes both related to pituitary diseases and hypothalamic diseases. Infiltration may be affecting both pituitary and hypothalamus, trauma, infarction, infections. So you can see here shared causes causing both pituitary and hypothalamic affection ultimately or eventually leading to hypopituitarism. Let's pass through the causes. Invasive causes of hypopituitarism, they do represent the major causes of hypopituitarism, and the most common cause for invasion of the pituitary is they are said to be due to the presence of pituitary adenomas. So pituitary adenomas are classified according to the major classification of pituitary adenomas according to their size. Those less than 1 centimeter are said to be microadenomas. Those more than or equal 1 centimeter are said to be macroadenomas. So most probably, if I'm going to speak about hypopituitarism, so I'm going to speak about a sizable mass that may lead to compression of the anterior pituitary secreting cells and eventually leading to hypopituitarism. So invasive pituitary adenomas, we are speaking about macroadenomas rather than microadenomas. Despite that, in literature and in our clinical practice, we may find that large microadenomas, those from 6 to 9 millimeter, may rarely cause hypopituitarism. They are said to be more common to causes with pituitary macroadenomas. Hypothalamic tumors, despite being rare, may be another cause for hypopituitarism invasive causes. CNS tumors, those having supracellular relation to the pituitary gland. So as I've said before, that the pituitary lies or resides within the cella turcica. So if I'm having a mass supracellular, that's to say above the cella, it may compress the pituitary gland and will lead to hypopituitarism. The most famous tumors ever are said to be craniopharyngiomas. Craniopharyngiomas are benign tumors affecting either cellular or supracellular spaces. either arising from the pituitary stalk or from a supracellular position. These craniopharyngiomas, despite being benign, they are associated with increased risk of morbidity and mortality and should be adequately addressed and treated. Meningiomas, chordomas, optic gliomas, epidermoid tumors, and dermoid tumors are examples of CNS tumors having supracellular relation to the pituitary gland and may lead to hyperpituitarism. Pituitary metastases. So metastases to the pituitary gland, they are quite very, very rare disorders. So if I'm having metastases coming to the pituitary, the most common sites are coming from the breast and the lungs and the colon. However, they are not common in clinical practice. Anatomical malformation as paracellular aneurysm may be example or rare examples of invasion of the pituitary. Could you remember when I mentioned that I'm having quite rare congenital or developmental causes of hypopituitarism that may lead to pituitary failure, as for example septo-optic dysplasia. Septo-optic dysplasia is a rare congenital anomaly where there is congenital disorder of what is known as septum bladicum, which is the thin septum present between the two cerebral hemispheres. Those patients affected by this disorder will come presented with hemiplegia, midline facial defects as cleft palate, ear deformities, optic nerve atrophy, micropenis, and loss of the sense of smell, anosmia, together with growth hormone deficiency plus or minus TSH deficiency. Kallmann syndrome, a rare syndrome where there is abnormal migration of the cells of the responsible for GnRH secretion. GnRH secretion is the hypothalamic tropic hormone coming out of the hypothalamus and controlling the release of gonadotrophin GnRH. The GnRH controls the release of gonadotrophins LH and FSH. There is selected deficiency of GnRH and together with olfactory bulb degenesis, so the patient will be presented with hypogonadism central together with anosmia or hypozomia, that's to say loss of sense of smell or decreased sense of smell. Frolic syndrome is another rare congenital anomaly where there is adipogenital dystrophy. The patient is having again selected GnRH deficiency together with abnormal hypothalamus, damage to the hypothalamus, so the satiety center will be affected. This is why the patient will be presented with hyperphagia and morbid obesity together with central hypogonadism. These are quite very rare disorders in clinical practice. However, they are examples of hypopituitarism due to congenital causes. This is example or a diagram, a famous diagram for septo-optic dysplasia, where the classical findings present in such patients will be hypogonadism together with optic nerve atrophy and midline congenital defects. So invasion of the pituitary, as I told you, could be either due to pituitary adenomas or due to craniopharyngioma, the most important, the most famous example. So here is an MRI showing a fungating mass within the pituitary or compressing the pituitary coming from a supracellular extension. This is an example for craniopharyngioma. Infarction, Sheehan syndrome. This is a classical example of infarction of the pituitary gland that occurs directly after delivery in the early postpartum period. So what happens during pregnancy, that owing to the proliferative effect of estrogen on all tissues of the body, the pituitary gland will undergo hyperplasia, and this is why the blood supply to the pituitary gland, if it is compromised due to whatsoever severe hypotension postoperative or severe postpartum hemorrhage, it will lead to infarction of the pituitary because the blood supply going to the enlarged pituitary, which is normal physiological consequence of pregnancy, will be compromised to the pituitary, leading to its infarction. So simply Sheehan syndrome is a classical example of infarction that occurs in the early postpartum period due to compromised blood supply going to the enlarged pituitary gland, intrinsic or present in cases or in pregnant cases. So what happens? The patient will experience either severe hypotension or shock, or severe postpartum bleeding, and the pituitary gland will undergo infarction. The classical presentation of Sheehan syndrome, or the early presenting symptom of Sheehan syndrome, because of the development of pituitary failure, that the female will fail to lactate her own child because the prolactin is failing owing to infarction of the pituitary gland. Afterwards, the patient will experience amenorrhea because the gonadal function will be lost. Growth hormone will be deficient afterwards. Then the thyroid and the adrenal glands will be failing under the effects, or under the infarctive effect of the pituitary gland present in cases with Sheehan syndrome. Mind you that hypopituitarism is quite common endocrine consequence in patients experiencing severe postpartum hemorrhage or severe hypotension following delivery, and is said to be present amounting up to 1/3 of patients having severe postpartum hemorrhage. 1/3 out of them, or 1 out of 3, will experience Sheehan syndrome. Another example for infarction of the pituitary is the pituitary apoplexy. Pituitary apoplexy is acute endocrine emergency. It is a fulminant clinical syndrome. What happens? Hemorrhage inside the pituitary gland. As you can see here, hemorrhage inside the pituitary gland itself. Usually cases with pituitary apoplexy experience the presence of the pituitary adenoma. So most probably hemorrhage due to pituitary apoplexy, or encountered in cases of pituitary apoplexy, will be associated with the presence of pituitary adenoma. Very rare that hemorrhage can occur in a normal pituitary gland. And when we see cases having pituitary apoplexy affecting normal pituitary gland, most probably it occurs in pregnancy. As I've mentioned before, that the pituitary gland during pregnancy enlarges under the proliferative effect of estrogen. So the classical pituitary apoplexy occurs in conjugation with the presence of a pituitary adenoma. So hemorrhage occurs within the pituitary gland, and because hemorrhage occurs, there will be classical presentation or classical manifestations of intracranial hemorrhage, together with massive enlargement of the pituitary gland, together with lateral extension of the pituitary gland and compression on the lateral anatomical structures of the pituitary gland, namely cranial nerves. So the patient will be presented with sudden onset of ophthalmoplegias, blurring of vision, sudden onset of severe headache, meningismus, neck rigidity secondary to intracranial hemorrhage, and acute hypotension, because by the presence of the hemorrhage there will be acute compression of the pituitary gland. ACTH secreting cells will be compressed, leading to sudden drop of cortisol, so the blood circulation of the patient will be definitely compromised, and the patient will suffer from circulatory collapse, severe hypertension, and if the patient is left neglected and untreated, high mortality rate will issue. So this is an acute endocrine emergency. We need to pick up cases as early as possible. We need to give plasma expanders. We need to give water to the patient, adequate electrolyte balance, together with acute administration of steroids in order to restore the circulation, restore the deficient cortisol level, and then the patient will be referred to surgery. So the acute or the rapid immediate measures for pituitary apoplexy treatment would be in the form of water and electrolyte balance together with steroids. Mind you that this is an acute endocrine emergency. You need to pick up cases as early as possible in order to avoid high rates of mortality. What about the predisposing factors for pituitary apoplexy? Definitely arterial hypertension, major surgeries, coagulopathies, the usage of anticoagulation, thrombolytic and antiplatelet therapies. Sometimes it may follow a pituitary endocrine stimulation test. Estrogen therapy may be encountered in pregnant cases and in early postpartum period. It could be a side effect of certain medications, namely dopaminergic agonists, capergolin and bromocriptine, clomiphene citrate, GnRH agonist. It may be a rare consequence for radiation therapy, head trauma, pituitary surgery, and targeted pituitary irradiation, namely gamma knife therapy. Another cause for hypopituitarism: infiltration by chronic granulomatous diseases as sarcoidosis, histiocytosis X, or a disorder known as hemochromatosis. Hemochromatosis, that's to say, iron deposition within various tissues all over the body due to increased iron level within the blood. Most probably hemochromatosis occurs in patients receiving repeated blood transfusions, say for example for patients having thalassemia or in other forms of hemophilias. Hemochromatosis may infiltrate the pituitary, leading to panhypopituitarism, and this is an MRI example for a patient having panhypopituitarism due to infiltration of the pituitary with hemochromatosis. Injury is another cause of hypopituitarism. Boxing. This is why boxers need to wear a shield or a helmet in order to avoid affection of the pituitary, or fall from height. Sometimes we may find patients, especially children, falling from height on their head, experiencing head trauma, and the patient may suffer from graft mutation afterwards because of the affection of the pituitary. Immunologic. Another cause for hypopituitarism is a rare cause for hypopituitarism. This disorder is known as lymphocytic hypophysitis due to autoimmune disorder affecting the pituitary gland. Most probably it occurs during pregnancy or in the early postpartum period. It enters in the differential diagnosis of a mass lesion because cases having lymphocytic hypophysitis will be presented with a pituitary mass together with thickening of the pituitary stalk and may enter in the differential diagnosis of pituitary adenomas. As I have mentioned, it is an autoimmune process with extensive infiltration of the gland by lymphocytes, histiocytes, and other plasma cells and cells engaged in the process of autoimmunity. Because autoimmune disease, they do cluster together, almost one half of the patients having lymphocytic hypophysitis may experience other autoimmune disease, either endocrinal or other autoimmune diseases, other systems all over the body. As I've mentioned before, it should be entered in the differential diagnosis of pituitary masses in pregnancy and in the early postpartum period. The vast majority of cases having lymphocytic hypophysitis will be presented with isolated pituitary failure, namely ACTH deficiency or prolactin deficiency. The last eye in the 9 eyes of hypopituitarism, or I guess the 8th eye, is iatrogenic. Sometimes patients may have failing pituitary post-surgical due to surgeries related to the pituitary gland, or post-radiotherapy. If the patient is offered radiotherapy targeted to the pituitary gland, the most common side effect of radiotherapy, either conventional or targeted radiotherapy, would be hypopituitarism. This is why patients receiving radiotherapy targeted within the pituitary gland should receive follow-up of their pituitary profile lifelong, because the incidence of hypopituitarism increases annually because of the cumulative effect of irradiation targeted to the pituitary. The last eye, the 9th eye, is isolated hypopituitarism. That's to say, only one deficiency of a selected hormone, growth hormone deficiency, ACTH deficiency, TSH deficiency, gonadotrophin deficiency, or prolactin deficiency. What about the signs and symptoms? As I told you, the main factors controlling them, the rate of onset, together with the extent of hypothalamic pituitary end organ damage. So if I'm having a patient having ACTH deficiency, it will result in adrenal insufficiency. TSH deficiency will lead to failing thyroid and hypothyroidism. Gonadotrophin deficiency will lead to hypogonadism. Growth hormone deficiency will lead to short stature and stunted growth in children, while will lead to adult growth hormone deficiency in adulthood period. ADH deficiency will lead to cranial diabetes insipidus, classically presented with polyuria and polydipsia. Growth hormone deficient secretion may lead to, as I've mentioned, decreased growth in children. In adults, it will lead to decreased sense of well-being and lower quality of life. Hypogonadism, central hypogonadism in patients of hypopituitarism will lead to amenorrhea in females, decreased libido and erectile dysfunction in men. Hypothyroidism, classically presented with cold intolerance, dry skin, abnormal cognitive function and mental dullness, bradycardia, constipation, are said to be present in cases of hypothyroidism, then affection of all metabolic processes within the body. ACTH deficiency, cortisol deficiency, mainly presented with nausea, vomiting, anorexia, weight loss, loss of appetite, low-grade fever, hypotension, abdominal pain, and definitely hypoglycemia, as cortisol is said to be one of the main counter-regulatory hormones in our body. ADH deficiency will lead to cranial diabetes insipidus. If the patient is having pan-hypopituitarism, we are going to find the patient having a paler look. The skin is fine, pale, smooth, with wrinkling of the skin due to growth hormone deficiency, premature wrinkling of the skin, that's to say premature senility changes. The body hair, pubic hair, and axillary hair will be lost as deficient adrenal androgens and deficient gonadal androgens on the other hand. Postural hypotension, that's to say that the patient will experience dizziness of standing, a sudden drop of blood pressure if the patient is sitting or lying on the back, and then suddenly standing owing to the deficiency of cortisol, bradycardia, decreased muscle strength and bulk, delayed deep tendon reflex because of hypothyroidism. Maybe the patient will suffer from abnormal visual field owing to the presence, say for examples, of supracellular tumors. What about the investigations? Because we are using ultrasensitive ways for estimating the thyroid stimulating hormone, so thyroid stimulating hormone together with free T4 will be sufficient in order to diagnose cases having central hypothyroidism. In cases of central hypothyroidism, TSH will be either low or normal, together coupled with a low free T4. Serum prolactin, because ultrasensitive ways, direct estimation of the prolactin levels will be sufficient in order to diagnose prolactin deficiency. However, gonadotropins, growth hormone, and cortisol, because the level of the hormones are fluctuating all over the day, we need dynamic blood testing. That's to say, you are going to give something to stimulate the release of these hormones out of their glands, and we are going to see if the patient is going to be stimulated well and good. This patient is not suffering from any deficiency. If the patient is having altered or abnormal diminished secretion of these hormones, most probably we are facing a deficiency of this targeted organ. So for growth hormone, we are going to use stimulation tests for growth hormone secretion, namely clonidine, arginine, aldoba, and glucagon. For cortisol, we are going to use ACTH stimulation test. Insulin tolerance test is a test used to stimulate both growth hormone and cortisol, so it could be used in order to diagnose cases having growth hormone deficiency and cortisol deficiency. Estimation of the gonadal axis by direct estimation of LH, FSH, free testosterone in males, estradiol in females, and by the usage of endocrine stimulation test, the GnRH stimulation test. So this is a quick diagram. How am I going to approach a case of hypopituitarism based on clinical history and examination? If I'm going to suspect pituitary hypofunction, I'm going to order thyroid function tests and sex steroids. If they are going to be low or low normal, most probably I'm going to diagnose cases of central hypothyroidism and hypogonadism. For cortisol and for growth hormone, I'm going to use endocrine stimulation test. What about the treatment? For ACTH deficiency, ACTH controls the secretion of cortical hormones, namely cortisol and adrenal androgens. This is why in cases of ACTH deficiency, we need to replace both of them. But because the vast majority of androgens present in the body is coming out of the gonads, no need to replace adrenal androgens, sufficient to replace gonadal hormones if the patient is suffering from central hypogonadism as well. So for a central ACTH deficiency, the main hormone to be replaced would be cortisol hormone. Am I going to replace the aldosterone because it is released out of the adrenal cortex? No, I'm not going to replace it, because ACTH has nothing to do with the control of aldosterone. Aldosterone is controlled mainly by the RAS system and the solids in our body, namely potassium and sodium, so mineralocorticoids won't be replaced in ACTH deficiency, and it is sufficient only to replace cortisol. Either replace cortisol by the physiological, naturally present hormone, the hydrocortisone at the dosage from 15 to 25 milligram per day, or the synthetic steroid, the prednisone or prednisolone, at a dose of from 5 to 7.5 milligram daily. We need to inform our patient that cortisol is a stressful hormone, and you need to increase the dose during periods of stress. That's to say, if the patient is going to pass to a major surgery, if the patient is having acute severe infection, acute stressful condition in his life, he needs to increase the cortisol level. For thyroid, in order to replace, we are going to use the tetraiodothyronine, the levothyroxine sodium. And you are going to follow up your patients with the targeted thyroid hormones T4, and you're not going to follow your patients with TSH, because TSH is already deficient coming out of the pituitary, so you need to replace your patient with the targeted hormone, the tetraiodothyronine or the T4, and we need to keep it at the upper limit of the normal reference range of normal. Mind you, if your patient is having combined hypothyroidism and hypocorticism, you need to replace adrenal cortisol before replacing thyroid, because if you are going to replace the thyroid before replacing cortisol deficiency, the patient will enter in adrenal crisis, because if you are going to give thyroid hormones, you are going to increase the basal metabolic rate, you are going to wash the already very minute levels of cortisol present in the patient body, and the patient will enter in adrenal crisis. So if you're having combined hypothyroidism and hypocorticism, you need to replace cortisol before replacing thyroid, say for instance by 5 days up to a week, and then you are going to go for combined cortisol and thyroid. So never replace thyroid before cortisol in patients having combined hypothyroidism and hypocorticism. For growth hormone, there is recombinant growth hormone. Definitely they will be of great value in children, however of questionable values of adults, owing to its high cost. It's quite very expensive, so we are selecting growth hormone to be given to the adults, those suffering from severe manifestations related to growth hormone deficiency, based not only on endocrine investigations based on growth hormone stimulation tests, but also upon questionnaire for the assessment for the quality of life, to what extent it is affected by adult growth hormone deficiency. For gonadotropins, it is based if the patient is in need to restore menstruation, say for instance for females, or to restore the sexual potency and sexual desire in male, we are going to give the targeted sex steroids. If the patient in need for conception, the patient is seeking fertility, you are going to replace the gonadotropins themselves, namely the LH and FSH. However, LH and FSH, they are not classically given to patients suffering from central hypogonadism, except if the patient is seeking fertility. If the patient is only suffering from menstrual irregularities, or if the patient is suffering from classical presentation of hypogonadism, namely decreased sexual desire, decreased potency, abnormal bone density, so I'm going to replace by sex steroid. So sex steroid, the mainstay for treatment of central hypogonadism, unless the patient is seeking fertility, I'm going to offer the patient combined LH and FSH therapy. And by here I end my presentation. I do thank you.